Now let us discuss medicine questions of Neet 2019. First question, a man who is a chronic alcoholic will develop which type of cardiomyopathy? We have option of HOCM, dilated cardiomyopathy, restricted cardiomyopathy and Takotsubo cardiomyopathy. The answer of this question is dilated cardiomyopathy. Now why is this the answer? Well, HOCM is usually congenital, it is autosomal dominant condition. It can occur as a sporadic also, but alcohol is definitely not a cause. As far as restricted cardiomyopathy is concerned, it is caused by amyloidosis. Sarcoidosis. Okay. It can also be caused by endomyocardial fibrosis. And it's also caused by eosinophilic infiltration of myocardium. So-called Loeffler syndrome. Okay. Now let's see what are the causes of dilated cardiomyopathy. Okay. Well, the predisposing are chronic alcoholism. This question also came in AIMS 2019. That's a very, very important question. Drugs which can lead to DCM are doxorubicin. This is the most commonly asked question. The other drug which is just similar to that is daunorubicin. It's again a cardiotoxic drug. Cyclophosphamide, cocaine, imatinib and trastuzumab. Point to be noted here is cocaine is not only it lead to DCM, but it can also lead to coronary spasm. So it can also lead to coronary artery disease, which is much more common as compared to dilated cardiomyopathy. Well, DCM can be autoimmune sometime. It's very common to have in peripartum or postpartum, that means during pregnancy, even after delivery also, up to 6 months of postpartum, this can be there. This can be sometimes congenital, which is an X-linked recessive disorder. Selenium deficiency is a very, very important cause, very frequently asked question. Duchenne myopathy. Well, this is a type of inherited type of myopathy, disease in children. Well, some people pronounce is Duchenne, some Duchenne, Duchenne, different type of pronunciation are there. But Duchenne is the one which is most commonly. That's why I'm saying Duchenne. Well, there are many other type of muscle dystrophy in children, but none of them lead to cardiomyopathy except Duchenne type of myopathy. Friedreich ataxia is again a cause of DCM. Hepatitis C is something unique question. Out of A, B, C, D, E, only virus hepatitis which can lead to DCM is hepatitis C. Glycogen storage disease like Pompe disease. This question came in AIMS May 2019, and this came in May 2016, and this came in November 2016, which can lead to dilated cardiomyopathy. Question number 2. Which the following statement is true about bundle of Kent? A normal pathway between the two atria, not at all. It's a muscular pathway between atria and ventricle in WBW syndrome. Yes, this is correct. It has slower than the AV nodal pathway. Is wrong. None of the above. No. The answer is B, if you rule out. So let's talk more about WBW syndrome. Well, as I told you, the answer is B. Well, the pathway. Now this is the atria and ventricle. We have a abnormal pathway connection between LA and LV. And it is this type which is known as type A of pre-excitation syndrome, also called type A WBW syndrome. Or the connection may be between RA and RV. And it is this entity what is known as type B, type of pre-excitation syndrome, also called type B WBW syndrome. Okay. So now, what's the disadvantage of this? First of all, well, like in this case, this is the abnormal pathway, SS3 pathway. Now they have now we all know that AV node has a maximum refractory period. That means whatever impulse comes here, they slow down here. But in contrast, accessory pathway, they are very fast. They are not slow, as shown in the option D. Option C, they are not slower. They are faster than. Because that's the reason why they develop. They can develop PSVT. Now, this can be, look, this is orthodomic. That means impulse coming from SE node to AV node, impulse goes, and now it is going back. We are getting re-entry phenomena. Point to be noted, if it is going from normal AV node, then coming down, then via accessory pathway coming down, this is known as orthodomic type of circular tachycardia. But at time, impulse may come from SA node to accessory pathway. Now it goes like this. This is known as antidomic type of re-entry tachycardia. Now, before I talk more about these two, let me tell you what happened in ECG in WPW syndrome. You get a short PR interval. PR interval less than 0.12 second. Just to inform you, normal PR interval is more than 0.12 second. In fact, normal PR is 0.12 to 0.20 second, but here it is less than 0.2. That means 0.12, that is short PR interval. Plus you get a notch in the ascending limb of R wave, so-called delta wave. Plus you get a wide QRS. Wide QRS. They are the three classical features about WPW syndrome. But here I like to tell you something unique which is not known to most of students. Now I told you two types of WPW syndrome. One is orthodomic and other is antidomic. This ECG finding, what I am talking to you, it is seen in this variety. In this variety, PR interval is normal. This is very, very important question for you, not known to 99% people are not aware that not in all cases of WPW syndrome, there is a short PR, only in those cases where there is antidromic circulation is there. Because if impulse comes from AV node to, SA node to AV node, then it will be having normal PR interval. Okay, right? And this how well ultimately impulse they generate is PSVT, about which I'll be talking to you in the coming slides. Now, question number 3. We got a 20-year-old patient presented with breathlessness and chest pain. His vitals are 80/60. That means he is in shock, because systolic BP below 90 is what we call as shock, whatever reason it may be. But since it is associated with cardiac condition, so we can say a type of cardiology-induced shock. Pulse tachycardia is there, okay, and we are getting O2 is 91%, but the best line management. If you look into this ECG, you are getting a PSVT type of picture. Okay, in PSVT, the main thing is his BP is low, he's in shock. Let us see what the best treatment is: cardioversion. Why? Look at PSVT. Here, it's a sudden episode of atrial tachycardia. Atrial rate is very, very high, okay? And narrow complex tachycardia, QRS interval is in the normal range. This is what we differentiate from. This is what we differentiate from so-called broad complex tachycardia, which originate from the ventricles. Mostly due to circus movement of re-entry, which occurs maybe in the AV node. That means this is the AV node. Impulse comes from SA node, it comes, and the circle may start in the AV node itself, or it may start from the bundle of his, also called bundle of Kent, which AV node, this is the bundle of Kent, and some circles start, which I showed you in the previous slide also. Okay, accessory pathway. WPW syndrome can also lead to PSVT. Now, how to manage a case of PSVT? Well, if patient is hemodynamic stable, okay, then in that case, we can go for vagal maneuvers like Valsalva, or we can use ejection adenosine, or even we can use verapamil also. If they terminate, fine. If not, then you can go for injection ibutylide or AV nodal blocking drug, or we can go for injection procainamide plus AV nodal blocking drug, or we can go for cardioversion. But this is done when the patient is stable. But if, of course, stable, but if the patient is not stable, like our question, where the BP is 80/60, then the best answer shall be cardioversion. Now let me tell you what the difference between cardioversion and defibrillation. Cardioversion we always do it's a well-planned procedure because it is usually done in atrial flutter or atrial fibrillation. Defibrillation is done in VTEC or VF. And both these are dangerous conditions. They can occur any time, and they occur in the terminal phase. So they are usually of sudden onset. Okay, so we can't wait here. If we have to do it, we have to do it immediately. But in this case, in atrial arrhythmias, we can wait, we can plan. If the patient is on digoxin, we have to stop digoxin before we go for cardioversion. It's a synchronized shock. Here is unsynchronized shock. Low energy shock, usually between 50 to 100 joules. Here it is high, maybe 250 to 300 joules. So it can be done with some delay. We can wait because atrial arrhythmias are usually not as fatal, but they are. Ventricular fibrillation is just like cardiac arrest, and that's why it has to be done immediately. So no delay, you have to do it immediately. Anticoagulation is needed usually in atrial arrhythmias because in these cases, clot formation can occur. Thromboembolic phenomena is very common in atrial arrhythmia. It's not a problem in ventricle. That's why we don't need any anticoagulant. Less damage to myocardium. Why? Because less energy is there. And here more damage to myocardium because you are using too much of the joules, 300 joules. Very powerful energy. It may really, you can say, type of really damage the myocardium by very high amount of energy. Use in most arrhythmias except VT-VF, and we use in VT-VF. I hope things are clear to you. Question number 4. Identify the ECG. You can see there are P waves followed by one QRS. It's a classical ECG picture of atrial flutter. In atrial flutter, this is much better seen in this. You are getting like sawtooth appearance of ECG, atrial flutter. Let's learn more about atrial flutter. The atrial beat at the rate of 200 to 350. And they usually have 2:1 block. What do you mean by that? Suppose 300 impulses are coming from SA node. This is the SA node. They come to AV node. Now 300 impulses can't be transmitted into ventricle. Now what AV node will do? Maybe because, and we learned that AV node has a maximum refractive period. So many impulses, they are coming here, but they are usually stopped at AV node only. Maybe 150 impulse go due to 2:1 block. So some type of concealed blockage is there. 2:1 block will be there. Okay, it may be 3:1 also. Suppose 100 impulse come down, then it is 3:1 block is there. And usually due to re-entry circuit in the atrium. Now you can see a beautiful ECG, sawtooth appearance. This is 1 P wave, 2, 3, 4. In this case, we are getting 4:1 block, sawtooth appearance with AV block. How to treat? You can control ventricle rate with digoxin because okay, and we can use verapamil, beta blocker, amiodarone, flecainide. DC shock, as I told you, cardioversion, if patient is hemodynamically compromised. Point to note it, this is only if the patient BP is not getting control, then only we give DC shock. Or we can go for permanent pacing by overdrawing tachycardia, or we can use implantable automatic defibrillator, can be lifesaver, but this is usually not required in atrial arrhythmia. It's more required in ventricular arrhythmia. But in case a patient has recurrent problem of atrial arrhythmia, then we can think of doing in atrial arrhythmias also. Question number 5, deep vein thrombosis, which is incorrect. Clinical assessment is highly reliable. Yes, this is true. Bilateral, no, this is usually unilateral. This is wrong. Most common clinical presentations, pain and tenderness in the calf, this is correct. Some cases may directly present pulmonary embolism, this is also correct. The answer of this question is B. So now when we talk about deep vein thrombosis and pulmonary embolism, we use Wells score or Wells criteria. What are the points? And we give points. If the patient is a case of active cancer or treatment, we give 1 point, because this is very common in deep vein thrombosis, very common in active cancer. Calf swelling, okay, 3 centimeter compared to asymmetrical asymptomatic calf. I told you it's a unilateral phenomena. So you can very well compare with the normal calf, and we compare, and it is swelling is there more than 3 centimeter, okay, then you give 1 mark. Swollen unilateral superficial vein, you give 1 mark. Unilateral pitting edema, you get 1 mark, of course in symptomatic leg. Previous documentation of DVT in a setting of deep pulmonary embolism, you can give 1 mark. Swelling of the entire leg, you give 1 mark. Localized tenderness, 1 mark. Paralysis or recent cast immobilization of lower extremity, you give 1 mark. Recent bed return due to whatever reason, maybe surgery, maybe postpartum, 1 mark. Or alternative diagnosis is least likely, okay, you give, okay, you give, give 2 marks. Well, now question number 6, risk factor for Alzheimer's disease include Klinefelter, no, Noonan, no, Down syndrome, yes. The answer to this question is C. Let's see what are the risk factor for a case of Alzheimer's disease. Old age, definitely is not a problem of the young. Why? Because it is a degenerative disorder. So degenerative disorder do not occur in the young patient usually. Low education, positive family history, females is much more in females. Past history of head trauma with concussion can be a predisposing factor. Aluminum intoxication, mercury toxicity can lead to this problem. Whereas prion disease, typically Creutzfeldt-Jakob disease. Genetic factor, Down syndrome, trisomy, okay, that is APP gene on chromosome 21, pre-senilin 1 gene on chromosome 14, pre-senilin 2 gene on chromosome 1, ApoE4 gene on chromosome 19 is the single most important biological marker, ApoE2 gene on chromosome 14. It is bit protective for Alzheimer's disease. Point to be noted very carefully. Well, the new thing, increase in blood homocystine level. This question came in Neet 2017. Diabetes is one of the strongest predisposing factor for Alzheimer's disease. This is a huge topic of discussion. It's a recent update. This question will be fairly like to come to you in the next exam. Now, something extra point that you should know. Smoking is not a cause of Alzheimer's disease, and use of NSAID may reduce the risk of Alzheimer's disease. Well, which of the following is included in the essential major blood culture for infective endocarditis? Single positive culture for Coxiella, single positive culture for HH, single positive for Corynebacterium, both A and B. The answer to this question is A, single positive culture for Coxiella. So let's read how we diagnose a case of endocarditis. We use Duke's criteria. Okay, the modified Duke criteria is like this. There are major criteria. Positive blood culture. Now, when we talk about positive two separate blood culture, point to be noted very carefully. And the common organism but we is staph viridans. This is especially common in those who are after dental procedures. Streptococcus Galacticus, HX group of organism, Staphylococcus. Now, point to be noted here is, in HX group we need 2 blood cultures. Why it is so important to talk of this? This I will be discussing the next slide. We continue with blood culture. Community acquired enterococci in the absence of primary focus, or a single positive culture for Coxella burnetii. Point to be noted, for Coxella we need a single culture positive, but in case of other HX group or other we need 2 positive culture. One more thing regarding Coxella burnetii, sometimes culture may not be positive. Even phase 1 IgG antibody titer more than 1 to 800 is also included in the positive. This is what the modified Dukes criteria is there. Well, let me discuss other major criteria is involvement of endocardium, and this you go by echocardiography. What all you have to see in echocardiography? Vegetations, this is the hallmark of or diagnostic feature is vegetation in endocarditis. Or we may get abscess, new partial dehiscence of prosthetic valve, or new valvular regurgitation, or change in the existence of pre-existing murmur. Okay, this is not sufficient. You need new valvular regurgitation is essential. Now, minor criteria include predisposing heart condition or injection IV use. Now, what are the predisposing heart condition? Any valvular heart disease, or any congenital heart disease, they all can predispose to endocarditis. The only notable exception are ASD, septum secundum, or MVP without MR. They are the only two conditions where it is least likely to occur or uncommon. Okay, IV drug abuse is a very common cause in young people, and it is usually involves the right-sided or in a heart that is usually tricuspid valve are involved. Fever, vascular phenomena like emboli, infarct, myocardic aneurysm, Jane-Way lesion, they all are minor criteria. Immunological phenomena like Osler scar, node, Roth spot, rheumatoid factor. Now, microbiological evidence, positive blood culture but not meeting major criteria. This is again a very important point. In major criteria of culture, they include positivity of those which are well-known organism like Streptovirus, Staphylococcus, HX group of those group. But uncommon group, if they are getting positive, then is a minor criteria, not a major criteria. And how to diagnose the case of endocarditis? We have got 2 major, 1 major or 3 minor or all 5 minor. Okay, if no major criteria is there, this is how we diagnose the case of endocarditis. MELD score includes serum alkaline phosphatase, transaminase, albumin, creatine. The answer is D. Now, what is MELD score? Well, when we are talking about of any chronic liver disease like cirrhosis of liver, we are using previously child book classification to assess severity of cirrhosis. It is based on serum bilirubin, albumin, presence or absence of ascites, neurological disorder or PT or INR, Prothman time or INR. Now, MELD score has also been introduced. Okay, it is based on, again, to assess the severity of a chronic liver disease, it is based on PT, which is there in child book also, serum bilirubin and serum creatine is also included in this. That means kidney factor is also included in this particular thing. Question number 9. Which of the following murmur increases on standing? The answer of this question is HOCM. Well, there are only 2 conditions where the intensity of murmur increases on standing as well as Valsalva. The first is HOCM. The second condition is mitral valve prolapse. Okay. Now let me discuss more about HOCM. In HOCM, first of all, it is a diastolic dysfunction. Diastolic dysfunction. Okay. Number two, there is obstruction to left ventricle outflow. Obstruction is there. But the main thing is this obstruction is not at the valve. Since it's a infravalvular obstruction, that's why there is no ejection click. And classically, usually it is autosomal dominant, but sometimes it may be sporadic also. And in this condition, there may be history of sudden death in the family. Since it's an autosomal dominant condition, so whenever we are dealing with the case of HOCM, it's essential to talk the family history of sudden death. Okay. Well, then, next point. In this, we get classically double apex beat. We get jerky carotid pulsation. You get third sound, you get fourth third sound. Then, in echocardiography, you get left ventricle hypertrophy. This you get in ECG also, and as well as we can document by echocardiography. But what is the more important in echo is SAM. SAM stands for systolic anterior movement of the mitral leaflet. I hope you have written this line. Okay. Now, what are the drugs which are contraindicated in this HOCM? Is very, very important question. Drugs which are contraindicated are digoxin, nitrates, diuretic, and beta agonist. They are all contraindicated. So I hope you are clear about HOCM. Now, Osborne J wave is seen in. This is seen in hypothermia. Let's learn what are the findings that you get in case of ECG finding. This is normal ECG. This is a T wave. So first finding that we get in hypothermia is bradycardia. Bradycardia means heart rate less than 60 per minute. Okay. Now, what else we get? Classically, you get a notch in the descending limb of R wave, and this is known as Osborne wave. Right? Now, what point to be noted? We are getting bradycardia. Let's learn what are the other causes of bradycardia. Bradycardia, it can be normal finding in elderly person. It may be normal finding in athletes. It may be normal finding during sleep. So they are the physiological cause of bradycardia. Otherwise, bradycardia also occur in hypothyroid. It also occurs in raised intracranial pressure. It also occurs in deep jaundice. It also caused by drug like beta blocker. It can also occur by complete heart block. When you palpate the pulse, you can find bradycardia is there. Okay. So, and of course, hypothermia is, as I mentioned, which can cause you to bradycardia. Now a question for you. Stop the video, write down the answer. I mentioned that beta blocker can lead to bradycardia. Tell me any other drug, new drug, which can lead to bradycardia. Well, I'm sure you've written the answer by now. The answer is ivabradine. This is a very, very important question. This will surely come in the next coming exam. So ivabradine is the one. Now, there's an extra advantage of ivabradine over beta blocker because beta blocker has a lot of side effects like bronchospasm. It marks the hyperglycemic symptom. It leads to erectile dysfunction, and so on. But ivabradine has none of these side effects. That means it doesn't have any systemic effect. That's a distinct advantage of ivabradine over bradycardia or over the beta blockers. Now, point out ulcer are seen in which condition? In esophagus during endoscopy. The answer of this condition is herpes zoster virus. Now, let me show you some beautiful pictures of various type of esophagitis finding. So, this is a multiple punched out lesion in esophagus starting from 25 centimeter from incisor in herpes zoster. Look at this beautiful picture. Another corrugated appearance of esophagus in eosinophilic esophagitis. This question came in AIMS, May 2018. Just see beautiful corrugated appearance. Then we have Candida finding in endoscopy finding of Candida esophagitis. Okay, white plaques with friability. Okay, and it rarely causes bleeding, perforation, stricture, or systemic invasion. That means more of a localized. And Candida, candidiasis esophagitis is very common in HIV patients. Barrett's esophagus, another endoscopic finding. This is seen in GERD. Okay, right. Now, what are the Barrett's esophagus? Let's learn the basic concept. So let's learn this normal basic concept about GERD. GERD is gastroesophageal reflux disease. This is the lower end of esophagus, and here is the stomach. Now we have a sphincter here, lower esophageal sphincter, what we call as LES. But remember, it is a physiological sphincter. That means there is no anatomical sphincter is there. It remains closed. That's why we call it physiological normally, but it gets opened automatically during swallowing. That's why we call it physiological sphincter. Now let's learn, and remember, here is the acid is there. Stomach is full of hydrochloric acid, and since it remains closed, what the main function that it prevents the regurgitation of stomach content into esophagus. That's why it prevents injury. Now let us see what happened. This is the low. Now let's see what the anatomy of the lower end of esophagus. And the lining of this is squamous epithelium lining is there. I'm talking about lower end of esophagus. That means I'm talking about this particular part. Okay. So now, due to repeated regurgitation, now there are many conditions where this remain open. That's why the stomach content can go up, and that can lead to esophagitis, right? Now, what happened initially? This lining, which is a squamous cell lining, it become columnar lining. Columnar. Right? And that's what we call as Barrett's esophagus. And this is known as intestinal metaplasia. Is this a very frequently asked question? And the main danger of this condition is this can go into adenocarcinoma. 40 times more chances of going into adenocarcinoma. Okay. Well, now regarding GERD, the most sensitive test for GERD is 24-hour pH monitoring. This question came in Neet 2018. And most accurate test for Barrett's esophagus is biopsy. This again, the question was one of the options in a case of Neet 2018. Now, next question number 12. Infarct involving which portion of the myocardium causes aneurysm as a post-MI complication? The answer is anterior wall MI. Now, okay, anterior transmural. Well, let's learn what is the problem. This is the myocardium, and this is the area where it got infarcted. And we know very well in the pathology, when the infarction occurs, the tissue becomes dead. And dead tissue, now it also loses the contractility. And at time when the infarct remodeling is not proper, now this may bulge out like this. And it can make a so-called aneurysm. Now, this aneurysm we can best diagnose by echocardiography. First point, very frequently asked question. What is the most dangerous complication? It is since this is a bulge and there is stoppage of blood, it's not contracting, it leads to clot formation, which can have embolism, which can have embolic phenomena. And when you do ECG of this, now in acute MI, this we get this typical finding. We get Q wave. We get finding like this. In acute MI, fully evolved phase, you get Q wave. This ST segment elevation, and this is a T inversion, T inverted ST segment elevation. This is what we get within about 24 to 48 hours. Now, suppose you take ECG of an old MI, maybe 3 months, then the only finding what there is Q wave. ST, T wave settle down to normalcy, but Q wave persists. Presence of only Q wave indicate old infarct. Now, if you get like this, there is Q wave is there and ST segment elevation is there, T wave is normal, maybe after 3 months of MI, that indicate aneurysm. Okay, persistence, that means persistence of ST segment elevation after many days, weeks or month indicate aneurysm formation, right? So let's learn more about LV aneurysm. It occurs late, maybe 5 days to 3 months. And this may present with left ventricle failure, angina, recurrent VT or systemic embolism. And it leads to mural thrombus formation, persistence of ST elevation. I told you we can best diagnose by echocardiography. And once you are getting clot formation, you have to give heparin followed by warfarin, because that can lead to systemic embolism into, maybe it can lead to CVA. So now look at this Q wave and ST segment elevation. And this is a beautiful picture of LV aneurysm. Okay? That's why whenever in the case of MI, we always prefer to give ACI, because that prevents the aneurysm formation. In fact, ACI help in the infarct remodeling. Question 13, which is not related to HIV, primary CNS lymphoma, tertiary syphilis, esophageal candidiasis, none. I think this is a very easy question, doesn't need much of a discussion. Well, I told you in the previous question, this is a very important feature of HIV. We also know that CNS lymphoma can have in HIV. Okay, now this is straightforward. Tertiary syphilis is nowhere related to HIV. Tertiary syphilis occurs due to syphilis only, due to Treponema pallidum, not due to HIV. But one thing is there. Of course, syphilis is a STD, HIV is a STD. In one patient, they may occur together, but overall, tertiary syphilis has got nothing to do with HIV. And of course, how does tertiary syphilis manifest? It can have a CNS manifestation or it can have cardiovascular manifestation. In cardiovascular, aneurysm formation is there. In CNS, classically, neurosyphilis can have all manifestation. Okay, the standard line, of course, nowadays, due to great advancement in treatment of syphilis, now tertiary syphilis is not seen that commonly as which was seen about 50 years back. Now, in those days, what it was a standard line that one diagnosis which fits into all CNS manifestation was tertiary syphilis. Okay. Now let's talk about question 14. A 26-year-old female patient presented with oral ulcer, sensitivity to light, that means photosensitivity, rash over the malar area, sparing the nasolabial fold of both sides. This is straightforward diagnosis of SLE. Sturge-Weber syndrome is more in children. Okay, dermatitis will not have oral ulcers, right? Psoriasis doesn't have a malar rash; they have a silvery scale, and in fact, psoriasis doesn't have photosensitivity also. And right, so straightforward the answer is SLE by ruling out others. Now, what is the classical finding which really favors syphilis? Malar rash over the face, and it classically spares the nasolabial fold. Whenever you are getting this line over the facial rash, you should think only about SLE, and it's strongly supported by photosensitivity. Okay, right? Now, let us see. Let's learn more about SLE. It's an autoimmune disorder more in females. They have a genetic and environmental predisposition. Anything which strongly favor environmental is drug-induced. In drug-induced, hydralazine, INH, procainamide. The mnemonic is HIP. Of course, there are hundreds of drugs which can lead to SLE-like condition, but these three drugs you should never forget. How we diagnose the case of SLE? Malar rash over the molar eminence, sparing the nasolabial fold, discoid rash, photosensitivity. The patient says, when I go to sunlight, my pollen increases. This is the classical butterfly rash, sparing the nasolabial folds, discoid rash. Carpet track sign or tin track sign, follicular plugging of the undersurface of adherent scales. Oral ulcer, which are painless. In our question also, patient has oral ulcer. Arthritis, non-erosive, very, very important point. Erosion means there is no destruction of the joint. That means when the pain disappears, the joint becomes totally normal. Polyserositis, patient can have pleuritis, pericarditis, ascites, renal involvement, proteinuria, RBC cause renal failure is the very common cause of death. Most common is membranous glomerulonephritis, neurological disorder, seizure, psychosis, stroke. In the blood, maybe hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia. Then ANA, this is the most sensitive test. Anti-double-stranded DNA, this is the most specific test. This is the most sensitive test. Okay, now I like to clarify one of the doubts. Anti-SM antibody. Now, different books mention different, which is this is more specific or more specific. It's a controversial. Examiner knows. So that's why these two are specific. And one thing I tell you, when if the patient, first of all, examiner never asks which is the most specific. He knows that there are two answers given in the different literature. Some books favor DNA, some favor. Now, I quote 20th edition of Harrison. What 20th edition of Harrison says? DNA double-stranded and SM, they are specific tests. Even Harrison doesn't mention which is more specific. Okay? So I hope things are clear to you. So even examiner has to ask, he'll ask any one of the options he will give, he will never give you two options. So other finding what can be there is anti-phospholipid antibody syndrome. This antibody which can lead to increased clot formation in the artery and vein. So SLE, the 4 or more criteria above are that they diagnose SLE. Type of sensation loss of the same side in Brown-Sequard syndrome is, the answer is proprioception. Why and how? Let's learn the basic concept about the Brown-Sequard syndrome. In the basic concept, you will never understand unless you know neuroanatomy. Basic concept. The basic concept goes like this. This is spinal cord. This is the pain, touch and temperature. they enter the cord. They relay on same side. They are the first order neuron. Second order neuron, they travel upward and they go to thalamus. And third order neuron, they go to contralateral parietal lobe. Same thing, pain, touch, temperature, they relay on same side. The second order neuron, they travel upward, they go to thalamus, and from thalamus they go to parietal lobe. Now this second order neuron, they are known as spinothalamic tract. This is the right side, this is the left side. Now if I ask you, they are the right side is spinothalamic tract. Now they contain which fiber? So definitely your answer shall be they carry left-sided pain, touch and temperature. Now this is the position vibration sense. They enter the cord. They travel upward without relay in posterior column. And from second order neuron, they go to thalamus on the other side, and finally they go to parietal lobe. Ultimately, all sensation, they go to contralateral parietal lobe. Okay. Now in syringomyelia, what happened? In syringomyelia, this central canal enlarges. This is central canal, normal central canal. This enlarges, syringomyelia. So as it enlarges, it involves both spinothalamic tract. Okay. So there will be bilateral loss of pain, touch and temperature is more on the arms as compared to leg. Now position vibration sense, they lie very far off, they are not involved. Okay, hence, so this is regarding syringomyelia. Now let's talk about Brown-Sequard syndrome. In Brown-Sequard syndrome, there is we cut one side of the spinal cord. Okay, so now one side of spinal cord is cut, there will be loss of ipsilateral position vibration sense, there will be loss of contralateral pain, touch and temperature. Okay, so now if you look into answer, sensation loss on the same side will be proprioception. Pain, touch, temperature, they are loss of the contralateral side. So with this basic concept, I hope you are clear about what happened in Brown-Sequard syndrome and what happened in syringomyelia also. Well friends, before I end my lecture, I have some more information for you. I have recorded the entire medicine lectures in my app, eGurukul app, and it is available on Google Play Store. Each and every topic in medicine has started from basic concept, and I have gone up to the recent advances, fully updated from 20th edition of Harrison. This is ideally for those who are preparing for Neet, AIMS, JIPMER, PGI, as well as undergraduates. Okay, and 15 to 20% of the questions of this exam will come from my notes, my lectures. You don't need to read any other thing. Okay, well, you can see some of the free lectures given in our official YouTube channel, and if you want to go know more about this, you can visit our website www.dbmci.com. Well, I have also written 2 books, very famous best-selling books. One is Medicine Simplified, it's a medicine textbook, and other is Medicine Essence, is a question bank with explanatory answers. Regarding this Medicine Simplified, which I said is popularly known as Mini Harrison. Now, a very commonly asked question to me, should we read Harrison or not? I say reading Harrison is absolutely contraindicated. But sir, why? People do ask me. Because reading 1 page of Harrison needs half an hour. To understand, you need 2 hours, and you need only 2 minutes to forget it. And Harrison is a ocean. You don't forget in undergraduate, you have to remember, you have to read 19 subjects. This is a simplified mini Harrison. I have given all crisp and concise approach to Harrison. It is given what you need to know, not that every detail which is not needed. Just like in first prof, people ask, should we read Gray? What you say, don't read Gray. You read Inderbir Singh or Chaurasia ki book, and Gray should be used as a reference book. This is the substitute for Harrison. This is for those who are doing undergraduate as well as those who are preparing for PG. This is a question bank, again based on Hassan 20th edition, containing all latest question. Okay, these books are available on Amazon and Flipkart also. In addition, you can very well join my group in Facebook, Dr. Bhatia Medical Forum, which you can actively talk to me directly. You can get all latest update, last minute revision points, and many recent updates which are not given in Harrison 20th edition also. I'll be talking to you. You can very well discuss with me. That means you are in direct contact with me. So this again one more way to assess me. Thank you very much for watching this video.